the Glasgow Coma Score. Hello. In the blink of an eye, a patient's level of consciousness can change. Today, we're going to discuss an important tool in acute neurological assessments, the Glasgow Coma Scale, or GCS. Developed by experts at the University of Glasgow in 1974, it's a widely used tool for measuring changes in level of consciousness. This essential tool helps us assess the depth of impaired consciousness and guide crucial treatment decisions. Anatomically, it determines the function of the upper brain, stem and/or both hemispheres. Let's dive into the GCS, its uses, strengths, and its limitations. The GCS is a scoring tool that measures a patient's level of consciousness based on 3 criteria: eye response, verbal response, and motor response. Each criterion is scored separately, and the scores are then added together to provide a total score between 3 and 15. A higher score indicates better consciousness. It may involve applying some brief, graded, non-injurious, non-marking, noxious stimulus to the patient when they are not responding otherwise. A score of 8 or less is generally considered coma. Eye response relates to how awake and alert the patient is. It's scored from 1 to 4, with 4 being spontaneous eye-opening and 1 being no eye-opening at all. Verbal response assesses the patient's ability to communicate. It's scored from 1 to 5, with 5 indicating oriented communication and 1 indicating no audible response. Motor response evaluates the patient's ability to control muscle movement. It's scored from 1 to 6, with 6 indicating obeying to commands and 1 indicating no motor response. Localization, or a score of 5, means that the patient reaches above the level of the clavicle toward the noxious stimulus above the level of the clavicle, or reaches across the midline to the noxious stimulus on the opposite side of the body. The GCS is a simple, reliable tool that correlates well with the outcome following severe brain injury. It relies on observable and reproducible responses. It's adaptable, allowing for rapid application at the bedside. It's also useful for tracking changes in a patient's condition over time. However, the GCS does have some limitations. It has a 56% sensitivity and an 82% specificity. The validity of the GCS can be compromised if the patient has been sedated, often leading to underestimation of patient scores. Also, it's not useful in detecting small, gradual improvements. The GCS can be influenced by factors such as pain, medications, toxins, language barriers, and others. Despite these limitations, the GCS remains an important starting point to assess and communicate the level of consciousness. Essentially, it is a key tool in the neurological assessment of patients with acute, endogenous, or exogenous brain injury. The GCS needs to be interpreted in the clinical context, alongside other clinical variables and its changes over time. As healthcare professionals, it's essential for us to understand and accurately use the GCS. Share this video with your colleagues to ensure understanding and consistent use of the GCS. Thank you for watching. Thank you for